teraz słychać. Dobrze. As it is 9 a.m., I think we can start the session of internal medicine. Esteemed jury, dear participants, listeners, ladies and gentlemen. Członkowie komisji, drodzy uczestnicy, słuchacze. On behalf of the Students' Scientific Society of Medical University of Silesia in Katowice, I would like to thank you all for coming and taking part in International Medical Congress of Silesia, SIMC 2022. My name is Martyna Giałbas, and I have an honor to moderate this session, and it is my pleasure. I would like to cordially welcome the esteemed jury, President of the jury, Professor Michał Cholecki, and members of the jury, Professor Cieślar, Dr. Romańczuk, Dr. Grzegorz Boryczka, and could you and Professor Grzegorz Piecha, sorry. We would like to explain you the rules of the session. The order of the presentation will be the same as in the abstract book. The maximal time for the presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusion and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. The assessment will be verified. All the presentations and the discussion must be run in English. I would like to remind you that if the work is presented in English, the discussion must be run in English as well. So both questions and answer have to be in English. We kindly ask you, jury, to assess the works on this specific aspect. Scientific value, way of presenting, discussion, and own contribution in the numbers from 1 to 6. When the session ends, we kindly ask you to give the cards back to the coordinator, to me, and to send the file reports cards back to the session coordinator in case of online jury members. Okay, so to begin, I think we can start the first presentation. So I would like to ask the presenter of the paper on the title of HIV-Allied Controllers, Clinical Characteristic, which I will open in just a minute. Okay, Agata Stokłosa and Katajina Żak. Let me just tell you when you will have your time started. Okay. Okay. Please start your presentation.
Good morning, I'm Agata Stokłosa. I represent Medical University of Warsaw. I would like to present you our scientific work entitled HIV-Allied Controllers, Clinical Characteristics. Allied controllers are a small group of HIV-infected patients who control their HIV viremia despite the lack of antiretroviral therapy. The mechanism of this phenomenon remains still unexplained. However, genetic factors are considered as one of the factors. Allied controllers have a stable CD4 cell count and maintain low and stable viral load. For most of them, the duration of the viremic control ranges from few months to even above a decade. In some of them, viral blips above the level of detection can occur. The last publications The last publications mention about increased immune activation and inflammation in HIV controllers compared with individuals who receive antiretroviral therapy and to individuals who aren't HIV infected. Therefore, allied controllers remain at increased risk for non-infectious complications of HIV infections, such as cardiovascular events. One of the analyses indicates increased frequency of hospitalizations in this group of patients. Unfortunately, no recent studies were found, as allied controllers are not common, and a multi-center study is hard to perform on such a small group of patients. It's not clear that the benefits of antiretroviral therapy outweigh the risk in these patients. This issue is still discussed. Polish, European, and British recommendations don't refer to allied controllers individually, but only indicate the necessity for treatment in all infected patients. The American guidelines recommend to initiate antiretroviral therapy in all HIV-infected allied controllers who have disease progression. We analyzed clinical and laboratory data of 5 HIV-infected patients in the following years with confirmed HIV infection. CD4 cells count above 400 cells per milliliter and viral load below 5,000 copies per milliliter, who didn't develop 8th stadium of the disease. Allied controllers form a heterogeneous group of patients. Their viral load can vary from undetectable to even above 4,000 copies per milliliter, as in the 5th case. This patient's viral load seems to be high in the comparison to the other patients. However, when compared to the average viral load in non-treated, non-controllers, it appears to be low. The first patient with undetectable viremia received the therapy at the beginning of his infection. The 5th one, with the highest viremia, decided to initiate the treatment 7 years after the diagnosis. And the second patient decided to interrupt the therapy for several times. This patient also suffered from recurrent cutaneous candidiasis. It was noted that when the therapy was suspended, the skin lesions in this patient were worsening. It should be emphasized that intermittent therapy isn't recommended by the actual guidelines, as it can cause increased risk for AIDS and non-AIDS derived clinical events. And the last 2 patients decided to not initiate the antiretroviral therapy, even though their viremia was above the limit of detection. Such approach is a common difficulty in this group of patients. To conclude, as we could see, allied controllers form a heterogeneous group of patients with various concomitant diseases. Due to wide access to information, we should discuss initiation of antiretroviral therapy with each patient to assure them of the benefits of this decision. And finally, antiretroviral therapy should not be stopped or interrupted, as it can cause additional clinical events. Thank you.
Thank you very much for the presentation and for opening the session for us. Dear jury, do you have any questions for our participant? Let me remind you that both questions and the answer have to be in English.
Could you explain us why the ART treatment should not be stopped and interrupted in this group of patients?
In this group of patients, the treatment shouldn't be interrupted in all HIV infected, as it can cause increased risk for AIDS. The viral load can increase, and it's more probable in HIV controllers that they can develop AIDS or in concomitant diseases, for example, infectious diseases.
Do you know the survival rate in these group of patients? I mean, about the patients in early controls? Survival rate?
Unfortunately, I don't know.
Okay.
In this study? So me and Katajina, we were working on this together. I think both of us, we made the same work.
Okay, any more questions to the participants from the jury, from the audience? Okay, if there is no more questions to the paper HIV-allied controllers, thank you very much for the presentation. The participant did not exceed time in both the presentation and the discussion. Thank you very much. So now we shall carry on with the the second paper, which I cannot see here, but I'm sure it was sent. That's my over. No, number 2, I guess, but I don't know why there is no number 2 in the folder. Oh my God, it's number 12. Okay, sorry. I'm so sorry. Thank you very much for helping me. I knew that we had a great president of the jury. Now it's the proof for that. Please welcome the author of the paper titled Varicose Vein Medical Treatment. What about the drugs? Iga Litwińska, Karolina Lesiakowska, and Julia Plewonik. For the future participants, there is a pointer there, so you can change the slides if you want. I don't have to do that. Can you see it?
Okay, yes.
Okay, thank you.
Okay, good morning, ladies and gentlemen. Thank you all for coming here today. Let me start by introducing myself. My name is Iga Litwińska and I'm third-year medical student. What would I like to present you today is our presentation about drugs in varicose medical treatment. Okay. Okay. Chronic venous disease, in shortest version CVD, is the most common vascular disorders. Symptomatology consists of the present symptoms and signs, venous hypertension, macrocirculation injury, inflammation, and large vein pathology. And there is an important component of chronic venous disease. Okay. what about pharmacology and main categories of venoactive drugs? Pharmacological treatment is one way of treating patients with CVD and can be used either as a standalone treatment or as an important component of combined treatment. Main categories of venoactive drugs are flavonoids, alpha-benzopyrens, saponins, other plant extract, and synthetic products. Okay, when we use venoactive drugs, we have specific symptoms and signs. For example, symptoms pain, cramps, restless legs, itching, heaviness, paresthesia, and signs such as swelling and venous leg ulcer. Okay, it looks simply, but if we come to pharmacy, it became a problem and patient can be confused because, for example, saponin and estin is the same molecules and it can be registered by many companies and in various indications. So it's the big confused for the patient, for example. And even better, if we open the internet and we know to get reduced varicose veins in 20 days, it's not true, and it's also so confused for the patients. Aim of the study, we compare the information available to the patient on the use of venoactive drugs with the current guidelines justifying the use of pharmacological treatment in defined indications. We analyze a big group of drugs and supplement. The next stage, we checked the indications in current guidelines based on the evidence of medicine and identify all drug and supplement to this specific group, for example, flavonoids, saponins, other plant extract, glycosaminoglycans, and other synthetic products. The treatment of symptoms in chronic venous disease in accordance with guidelines is based on the evidence of medicine and its current guidelines. All group with drugs and supplements have specific indications. Okay, so our results, the big group flavonoids, I think it's the most important, that registered for leg swelling have only 29% drugs and 20% supplements. Registered for leg pain and heaviness have only 100% of drugs and 20 and 40% of supplements. And registered for the leg cramps have 71% drugs and 20% supplements. It's you can see on the slide here, and only one drug, Diosminex, is registered for all indications, for example, pain, heaviness, pruritus, cramps, titers, and swelling. And surprisingly, what we found and noticed in our results, that one supplement and one drug have indication for vascular spider veins, and we are aware about it because any drugs haven't registered for these indications, and it's a little bit strange. The next group, rutin and rutosides, registered for leg swelling, 50% drugs and none of supplements. Registered for leg pain and heaviness, 50% drugs and 100 supplements. And it's important to notice that troxarutina, when we go to pharmacy, we have the same molecule, but 3 pharma companies producing this substance, and with many various indications. So it's the same situation. It can be confused for the patients. Okay, the next group, saponins, registered for leg swelling drugs 100%, supplements 57%. The next, registered for leg pain and heaviness, drugs 53%, and supplements 14% and 86%. And last but not least, synthetic products. Register for leg swelling and cramps, 75% of OTC drugs and 100 prescription drugs. And register for leg pain and heaviness, drugs 75 and 50%, and prescription drug 100%. Okay, the next important thing is the difference between dietary supplement and a drug. So it's a big difference between drugs and supplements, and also registration supplements and drugs in Poland, because the registration of supplements is more easier than the drug. Then a drug is more complicated, and we have to make a clinical research. Okay, so in conclusion, despite the widespread availability of benactic drugs and dietary supplements used in patients with CVD in Poland, both for physicians and patients, the widespread clinical use in our country is based on limited scientific evidence, or it's not reflected in the clinical studies performed or recommendations available. Thank you for your attention. Thank you very much. Now, if you have any questions, please don't hesitate to ask. Thank you.
Thank you very much for the presentation. And right now, I will give the microphone. So if you have any questions, please ask them to the microphone.
Okay, how would you name the situation that there is the lack of treatment according to novel guidelines? And in your opinion, what is the reason for this discrepancy between the registration and the clinical use of the drugs that you presented?
Okay, I'm not sure, but I think that Diosmina is a good example, because Diosmina, the registration of Diosminex, is based on documents of registrations on previous medications, for example, the Tralex. And all publications and registration medications based on the Tralex, and because of Diosmina is a generic medications, so it's quite similar, but not it's 100%, and I'm not sure about that.
Okay, there is something like clinical inertia.
Yes.
So the question is, in your opinion,
yes,
why do you think there is a situation when there are so many drugs that are registered in a precise clinical situation, but even though there is a huge knowledge about these drugs, the doctors use some supplements or something like that? There's lack of knowledge, the lack of the lack of knowledge about the guidelines. Why is it so? Why patients are not treated properly? How do you think?
Okay, so we have a big choice in the pharmacy, I think. So the patients use the supplements, and also in Poland, I noticed in preparation this presentation and our analysis that it's not so common knowledge by patients and the difference between supplements and the registered drugs.
Yeah, of course, the patients may have some lack of knowledge, but the question is why doctors have the lack of knowledge. But it's not your fault. Okay, thank you very much.
I think it is also because most of those drugs are OCT drugs, so over the counter, because so patients can buy them without even contacting with doctor.
Yeah, and the patient spends much more money for supplements.
Yeah, and they don't even go to doctor, and they don't get professional help, and they just spend money for the pharma companies.
Regarding the presented data, tell us what group of drugs should be, in your opinion, the group of choice in the treatment of the varicose veins? Is there any group of the drugs that you are convinced that it should be a valuable element of pharmacotherapy.
So, in my opinion, the flavonoids, the main group, the big.
And why?
Because our analyze, we have one moment. It's indications and our analyze of amount of percent indication if this in this group is the more higher, than the other group, for example, saponins, other plant extracts and synthetic product.
Thank you very much.
Thank you very much for the second presentation of today's session. And please, yes, a round of applause for the participants. And yeah, now it's in the right order. So please welcome on the stage the authors of the paper titled Comparison of Two Methods of Assessment of Body Composition by Marcin Schulz, Julia Cieśla, Piotr Kuczera, Natalia Tomecka and Maciej Pękała.
Thank you very much for invitation. It is a great pleasure for me that I can present you results of our study. Body is composed of different tissues like muscles, bones, internal organs, water. The assessment of body composition allows us to distinguish between fat body mass and lean body mass. Lean body mass is body water, bones, and muscles mass. Methods are used commonly in sport, but also in medicine for patients with heart failure and elderly patients. Assessment of body composition may enable to stop or constrain development of illnesses by administration of non-pharmacologic measures such as rehabilitation, physiotherapy, and healthy diet. Awareness of body composition can have application in risk stratification in frail sarcopenic patients. We have compared two methods. First, based on skin fold measurement method based on Jackson-Pollock formula, and second, using SECA MBCA 528 analyzer based on bioelectric impedance. To assess body composition using Jackson-Pollock formula, we need to measure skin folds in 3 points. For men, on the right side, on chest, on abdomen, and on the front of thigh. For women, also on the right side, on abdomen, on the rear side of arm, and on the front of thigh. Here are screens from program which calculate results. At the beginning, program demand to enter patient's name, age, gender, weight, mass, and mark level of physical activity. Then program demand skin fold measurements and waist and forearm circumference. At the end are shown results: lean body mass, fat body mass, percentage of body fat at its preferred level. In addition, program shows BMI and basic metabolic rate. This is the result of body composition for women, but we have to remember about different locations of skin fold measurements, and program demand only gluteal circumference. The pros of this method is that it's easy to use, it's inexpensive to buy instrument and also to exploit it, and there is a low impact of actual rehydration. The cons: there is a risk to make a significant measuring error, and method was validated only for young people. But if certainly, about it in the next part. We have employed SECA MBCA 528 analyzer. Method is based on electric resistance. It uses alternating current of frequency 5, 50, and 250 kHz. Device demand to enter patient's height and mass. Measures are made in lying position, and directly before measurement, patient shouldn't eat and do physical activity. Pros of this method is that it's easy to use, it's precise, there is a high repeatability of results, and method was validated for a wide group of age, up to 102 years old patients. The cost of method is that it's expensive. The costs of buying device are really high, but utilization is not expensive. The only cost is to buy disposable electrodes. Method is also contraindicated in pacemaker patient, and there is a high impact of actual rehydration. We have enrolled 15 people, 13 men and 2 women. 9 patients from the Frapica cohort, aged from 65 to 82 years, and 6 volunteers, aged from 22 to 55 years. Mean age was 54.5 years, mean height 1.75 meters, mean weight 83.7 kilograms, and mean BMI 26.8 kilograms per square meter. We have introduced results by Blunt-Altman analysis, which have application not only in medicine. It is used to assess usefulness and possibility of interchangeable application of measurement methods. Results are: average difference between 2 examined methods is 0.06, so average from 2 methods is near 0, so results fit in 95% examined population, so results are comparable. In conclusion, results analysis shows that both methods can be applied interchangeably. In addition, skin fold measurement method can be applied not only in young, but also in elderly, frail population. It is also useful in a pacemaker patient, whereas bioelectroimpedance method is contraindicated. Thank you for your attention. I will be pleased to answer your questions.
Thank you. Okay, but can I give you the microphone first? Thank you.
Okay, I have 3 questions. The first is, in which clinical situation the measurement of body composition may be helpful? That's the first question. The second question is, why BIA is contraindicated in pacemaker patients? And the last question is, as I can see, all the measurements you perform personally. Am I right?
Yes.
Okay, so only 2 questions to answer.
Okay. So coming to first the question, in my opinion, in obese population, measures will have very high value, because patients who are obese are in the risk group of cardiovascular disease and, for example, infraction of heart muscle. Coming into the second question, method is contraindicated in a pacemaker patient because patients who has a pacemaker has device which have electrical potential, and we have also examined people who has a pacemaker and device that didn't show results. There weren't any result.
Okay.
Could you explain us why the skin fold measurement should not be used in elderly people?
Why shouldn't be?
Why should not be used in elderly people?
Okay. Method based on skin fold measurement shouldn't be used where it is in the instruction of the device, but we wanted to present that it can be also applied in elderly patient. We have shown in the analysis that results are comparable, so we can also use skin fold measurement method in also elderly group of population.
Okay, thank you.
Thank you.
Thank you. How would you like to compare your findings with the fact that we have various number of, actually, high number of the analyzers of the body impedance? So perhaps yours works excellent, but on the market they are various. So shouldn't we use the skin fold measurement?
But could you repeat?
We have various high number of the analyzers of the devices on the market, yeah? So how would you like to face your findings with the fact that they might work in different ways? So the one analyzer might be excellent and another one might be poor.
Yes, for us, only SECA MBCA 528 analyzer was available, so we only used that analyzer. It is a new device in our study. In future, I think if we will have amount of money to buy on other measurement devices, we will compare them. But at this moment, we haven't any comparison between other devices which is based on bioelectric impedance.
Thank you very much, but we don't have a time for the more questions. We exceeded the time for the discussion, so thank you very much for the presentation. Thank you very much for the interesting questions we had. I guess we had more questions than the time, so let me invite you to talk about the topic after the session. So with the fourth paper, the assessment of liver fibrosis using FibroScan and Fib for a calculator in patients with liver steatosis, I would kindly ask Mirela Hendel, Anna Olejos, Krzysztof Irlik work to be presented.
Okay, so good morning, esteemed jury. Good morning, ladies and gentlemen. My name is Anna Olejos, and I have the pleasure to represent the Department of Internal Medicine, Diabetology, and Nephrology in Zabrze. I'm delighted to be here today to tell you about our research, assessment of liver fibrosis using FibroScan and FIB4 calculator in patients with liver steatosis. So my presentation is divided into 6 parts, and I'll begin with the background information. Non-alcoholic fatty liver disease, NAFLD, is the most common chronic liver disease worldwide, with its prevalence being about 1 billion patients. It is diagnosed in 40% of patients with hypertension, 60% of patients with diabetes type 2, and even up to 80% of patients with obesity. Some people think that NAFLD is a benign liver condition. However, it is the second most common cause of primary hepatocellular cancer and the end-stage liver disease. The high prevalence of NAFLD is driven mainly by unhealthy lifestyle, among others, dietary factors such as high levels of saturated fats, cholesterol, or fructose. The aim of our study was to determine the association between assessment of liver fibrosis using FibroScan and FIB4 calculator. So we should emphasize the fact that FibroScan is an expensive, time-consuming, and quite difficult to access in Poland examination, unlike FIB4 calculator, which can be carried out in everyday medical practice. FibroScan is a modified ultrasound examination of the liver, and the state of fibrosis is categorized as F0, no fibrosis, to F4, advanced fibrosis. On the other hand, FIB4 calculator is a liver fibrosis index based on 4 factors like age, aminotransferases, and platelet count. And the FIB4 score is expressed as advanced fibrosis excluded, further investigation, or advanced fibrosis likely. FIB4 calculator is designed for patients with NAFLD suspicion who are over 35 years old. So, for example, a 70-year-old patient with platelet count normal and increased aminotransferases gets the result 3.76, which corresponds with advanced fibrosis likely. The study was conducted on patients with obesity and NAFLD based on ultrasound examination between November 2019 and December 2021. The study has took almost 2 years, and we examined 190 patients. All of them underwent a FibroScan assessment and FIB4 calculation. Now let's have a look at the results of our study. On the basis of FIB4 score, 144 out of 190 patients were assessed as advanced fibrosis excluded, which corresponded with the low stage of fibrosis and amounted to median 1 and interquartile range from 1 to 2. Further investigation was advised for 36 patients, and median based on FibroScan amounted to 1, and interquartile range was from 1 to 2 based on FibroScan. Finally, 10 patients were assessed by FIB4 score as advanced fibrosis likely, which corresponded to the median 2.5 and interquartile range from 1.75 to 3.25 based on FibroScan. Our study has shown that FIB4 scores work very well for staging patients with no or minimal fibrosis. Meanwhile, FibroScan is needed at staging patients with advanced fibrosis. Identification of patients with advanced fibrosis, according to FibroScan, seems to be less precise due to higher interquartile range. However, interpretation of this data should be done with caution because of a small sample of patients, and further studies are needed on a larger group of patients. Coming to the conclusions, FIB4 calculator seems to be a valuable tool in everyday medical practice, allowing for a good prediction of liver fibrosis, especially, like I've said, in less advanced stages of fibrosis. Thank you very much for your attention, and that will be all from me.
Thank you very much for the presentation. The time was not exceeded. Let me just change to the last slide. Okay, thank you very much. And we have 3 minutes for the discussion. I'm passing the microphone. Okay.
Okay, thank you for the presentation. The paper is clear and very good. I have a question. Do you know the alternative name for non-alcoholic fatty liver disease? And there is a new acronym that was developed last year.
Of course. In 2020, NAFLD was redefined as MAFLD, so it is metabolic associated fatty liver disease, and this definition is combined of presence of steatosis in more than 5% of hepatocytes and one additional parameter such as, for example, obesity, diabetes type 2, or metabolic abnormalities. And there are no exclusion criteria like in the NAFLD definition, such as exclusion of alcohol consumption, more than 30 grams alcohol
Yes,
per
perfect.
day.
That was I wanted
and
to
also,
hear. Yeah.
what is quite important that MAFLD definition doesn't consist of the exclusion of any chronic liver diseases on the basis on immunological.
Right.
Yeah.
Thank you very much.
Was this study a retrospective or prospective one?
It was a retrospective.
Retrospective.
Study. Yes.
And so I understood properly that you did not make the FibroScan examinations yourself?
No, I didn't make this examination. This was quite a bigger study, and my intake was to recruit patients, to take interviews. We are asking patients about their chronic diseases, about medications they take, about their addictions like smoking, drinking alcohol. I was also making appointments for examinations. And we're taking anthropometric measurements and blood pressure measurements. I wasn't the person who pursued FibroScan examination.
So far.
So far, yeah.
And last short question. Do you think that using 5-4 calculator is enough to make a proper diagnosis, or should we use also the FibroScan examination?
Of course, FIB4 is not enough, but I think that my presentation and my conclusions underline the fact that FIB4 score, FIB4 calculator is a really valuable tool. It's cheap, and patients who come to us every year can have FIB4 calculations, because all we need is simple morphology and aminotransferases, and FibroScan is FibroScan, for me, in my opinion, could be refined for patients with advanced fibrosis likely score in FIB4 calculation, because it's refined only for patients with viral hepatitis, and patients with no disease must pay for this examination by themselves, and it's quite a huge cost, 300 zloty. Yeah.
Thank you very much.
Yeah, thank you very much. Thanks.
Okay, run out of time.
Thank you very much for the presentation, for answering questions of our jury. And let me invite the presenters of the work on the title of Comparison of the Infectious Course and Anti-Therapy in Patients with and Without Diabetes Mellitus, Agata Soleja, Alexandra Mrozkowiak, Maria Stec, Wiktoria Kuczmik.
Good morning, ladies and gentlemen, the committee. It's my pleasure to present a comparison of the infectious course and anti-therapy in patients with and without diabetes mellitus. It is believed that infections in patients with diabetes tend to be more frequent and present worse clinical course because diabetes interferes the whole organism and immune system. Aim of the study was to compare the course of infection and its treatment in patients with and without diabetes. The study was retrospective and cross-sectional. The primary analysis included 1,090 patients hospitalized at the Department of Immune Medicine, Autoimmune and Metabolic Diseases, University Clinical Center between 1st January and 31st of December 2021. Inclusion criteria was infection, whereas exclusion were oncological disease in patients' history and metabolic syndrome. The total number of 180 patients were included into the analysis. Among the studied population, median age was 67 years old, and 47% of our patients were female. Methods included analysis of clinical diagnosis, antibiotics used during the therapy, type of diabetes, laboratory parameters, in-hospital mortality, and statistical analysis. The cohort was divided into two groups, 76 patients with diabetes and 104 without. In both groups, the most common antibiotic were beta-lactams. Death ratio was higher in DM group, but the difference wasn't statistically significant. Glucose value was, of course, higher in DM group, and the difference was statistically significant. We measured initial and terminal CRP values. They were both higher in DM group, but the difference wasn't statistically significant. Other inflammatory markers like initial and terminal level of procalcitonin and leukocytes were measured too, but likewise different weren't statistically significant. Patients were hospitalized for 1 up to 35 days long. Median length of hospitalization in DM group was 10 days, and in the non-DM group it was 8 days. So it was longer period of time in DM group, but the difference wasn't statistically significant. Polyantibiotic was more often applied in non-DM group, to be exact 89.4%. Patients with diabetes were usually treated with 1 or 2 kinds of antibiotics in order not to overstrain liver kidneys. The most common combination was beta-lactams in accordance with quinolones. As I mentioned before, the most commonly used antibiotics were beta-lactams, and within them, third-generation cephalosporin. In both groups, they were followed by quinolones, nitroimidazoles, and glycopeptides. We can distinguish bigger differences in less commonly used antibiotics. Patients with diabetes were treated with sulfonamides and fosfomycin, and patients without with macrolides and aminoglycosides. The most common infection in DM group was pneumonia in the course of COVID-19. It was followed by urinary tract infections, pneumonia, Clostridium difficile, and sepsis. We can notice pretty similar order of infections in non-DM group. However, diverticulitis was more often diagnosed in this group, but the difference wasn't statistically significant. In direct comparison of these two groups, we can notice that urinary tract infections and sepsis was more often diabetes patients, but the difference wasn't statistically significant. We are aware of limitations of our study. Unfortunately, we weren't able to measure level of glycated hemoglobin because it's not a usual laboratory test in a presented unit. And because of COVID-19 pandemic, patients were transferred to different units and temporary hospitals. That's why we weren't able to collect data from the whole period of infection. The strict exclusion criteria, a lot of patients were enrolled into the study. That's why our study population is relatively small versus our primary number, 1,090 patients. Based from our study, we can conclude that although many complications of the diabetes are well known, the course of infection and its treatment seem not to differ significantly. It might be an effect of right treatment and well-controlled diabetes. However, we should keep in mind that every patient should be considered individually, and the chosen treatment should constitute as an optimized, effective therapy. Thank you for attention.
Thank you very much for the presentation. As I can see, other co-workers, co-authors of the work are joining us on the stage, so I'm giving you the voice and the microphone.
I have 2 short questions. First, the mean glucose serum concentration in this group, in group of non-diabetic patients, was 107. It is over the upper limit of the norm. How could you explain it?
Okay, so a lot of patients are from the emergency, so the level is not like from the morning examination, but a lot of these are emergency cases.
I see. And a second question. Why do you think, why in the group of non-diabetic patients, more kinds of antibiotics were used as what is for me a little surprising, because I could expect that the more groups of antibiotics will be applied in diabetic patients group.
I think it may be an effect that patients with diabetes have more liable organs, for example, kidneys. So we can use more spectrum of antibiotics in patients with better organs and with better GFR and other parameters.
Okay, you convinced me. Thank you.
Well, that's quite a good work if there is no more questions, I guess. Thank you very much for presenting. Thank you very much for the questions that were being asked. And right now we will proceed with the sixth work on the title of Clinical Manifestation of Hepatitis A Virus Genotype 1A Infection by Julia Henke and Krzysztof Bratek.
Good morning, everyone. My name is Julia Henke, and today I will be representing the Medical University of Warsaw with my research about the clinical manifestation of genotype 1st HIV infection. The virus is present worldwide. It is estimated that hepatitis A accounts for more than 50% of all viral hepatitis. It is transmitted via the fecal-oral route, close personal interactions, and contaminated food. 6 genotypes have been described, with only 3 circulating in humans: first, second, and third. The first one is the most common one. In 2016 and 17, in Europe took place a vast outbreak. Molecular analysis identified the genotype 1st of the virus. In Poland, we've also experienced an increment of the hepatitis A cases. And according to National Institute of Public Health, in 2017 was detected 3,072 cases, while in 2016 it was only 35. Hepatitis A is an acute, self-limited disease. Diagnosis is usually made based on clinical manifestation together with the presence of anti-HIV antibodies in serum. PCR can be also used to confirm the presence of the virus in stools. Hepatitis A usually manifests with jaundice due to hyperbilirubinemia, also nausea, stool discoloration, vomiting, fever, and fatigue. The prevalence range of different symptoms in the course of HIV in literature is wide. In our study, we included 2 papers from the current literature whose methods and issue were similar to the purpose of our study. We can see the statistically significant differences between the course of HIV genotype 1st and genotype 3rd A. And this is what those 2 papers are about. This is the first one, which describes the population of Sri Lanka. And the second one, written by Hye Sun-yoon, describes the Korean population. We, in our study, analyzed the history of patients admitted to our department. All of them, that time, were infected with the HIV genotype 1st A. All of them knowingly answered the doctor's question and talked about their signs and symptoms. We focused in our study on the symptoms that they reported during the admission to the hospital and also the laboratory findings. We also paid attention to age, duration of hospitalization, and also to genotype of the virus. We analyzed the 59 patients' cases. As I said before, they were all infected with HIV genotype first A, which gave us the ability to analyze the course of the disease for this particular genotype. The average length of hospitalization was 7 days, and no one from our patients developed fulminant hepatitis. All of them had an elevation of liver enzymes activity, alanine aminotransferase, aspartate aminotransferase, GGTP, and bilirubin concentration. Alkaline phosphatase was elevated only in 87% of cases. The main cause of which patients contacted the medical staff was jaundice, reported by 88% of them, although hyperbilirubinemia occurred in all cases. Fatigue and dark urine were the second and the third most common symptom that they reported. Other symptoms and their frequency are shown on the presentation. During the analysis, we were particularly surprised by the fact that the number of patients complaining of pruritus was disproportionately low in the relation of those with jaundice. In the paper, which describes the population of Sri Lanka, we can observe that jaundice was also the most frequent symptom, like in our case. The rarest one was diarrhea. In Korean population, diarrhea was also reported as the least often symptom, but nausea was the rarest one. In this moment, I would like to highlight that the paper about the Korean population did not contain the percentage of jaundice reports. To sum up, in Polish population infected with HIV that we studied, hyperbilirubinemia and pruritus was the most often and the rarest clinical manifestation respectively, and genotyping of HIV can be relevant in the evaluation of the course of the disease. Thank you very much.
Very much for the presentation, and before we proceed with the discussion, I would like to apologize to Dr. Karavetska and Karavetska, who joined us online that I was not aware of. I'm so sorry. Dr. Karavetska is with us, and if she wants to, she's pleased to answer any questions to the participants. I'm sorry I cannot see you at the Zoom right now, but if you can hear me, if you could say anything to show us that you are with us, I would be pretty grateful. Okay, I can see. Oh, thank you very much for showing up. We cannot hear you right now. Could you unmute yourself?
I hope so that now it's working.
Yeah, it is. Thank you very much for joining us. I'm so sorry for not introducing you with the rest of the jury. It's my terrible mistake. So right now, please proceed with the discussion.
Okay, that's no problem. Thank you. Well, good morning to everyone. All the presentations were very interesting. I was listening very carefully, and I want to congratulate all of you for all your work. Thank you. I will listen carefully in the next presentation too. Thank you very much.
What happened in 2017? So why we had 100 times more infectious than in 2016?
We are not 100% sure, but there is a conception that in 2016 took place a big party in Berlin where many of participants took part in. And there was some hamburger restaurant where the meat was infected with HIV, and this is the point 0 where when all those participants were infected, and then one by one where the disease were spreading. And the party took place in Berlin in 2016, but to our country it just came like I think a few months later, and this is why in 2017 the number of infections were so high.
It's quite a story, yeah, thank you.
How could you explain the differences in the frequency of particular symptoms between Asian population and Polish population? Because there were significant differences in the frequency of some of clinical symptoms.
Yes, can I come back to those slides with, maybe here. I think this is important to highlight here that in Asia, the genotype 3rd is the more common in Europe. In Europe, we like all, we also always, when we were genotyping the virus, the result was genotype 1st. And also in this vast outbreak in 2016 in all Europe, there was also the genotype 1st. But in Asia and in Africa, the genotype 3rd is more common, I can say. And I think that we are not particularly sure if we can say that in course of genotype 1st infection and genotype 3rd, we can see those differences clearly. And I think we need more research to confirm this hypothesis. This is why in my conclusion I said that we may see the difference, but those populations that were studied are not so high, because we have only 160 and 2,044 people in this research that were included. And I can't say here that we are 100% sure that we can see the difference, even if we say that we can see it clearly in percents. But yet there are no directives that said that the difference is showed. Yeah.
Thank you.
Yes, of course. Please, a huge round of applause for the participant. And we shall carry on with the 8th work of today's, the 7th work of today's session on the title of the correlation of TNL concentration and inflammatory markers in patients after liver transplantation by Maria Fota, Milena Małecka, Giełdawska, Justyna Malinowska, Emilia Czyżewska, and Olga Ciepla.
Okay, good morning. My name is Maria Fota, and I'm from Medical University of Warsaw. And the reason I'm here is to talk about the result of my study titled Correlation of Troponin I concentration and inflammatory markers in patients after liver transplantation. I would like to begin with some general information about 3 light chains. They are immunoglobulin, light chains which are circulating in serum in a free state, unbound. And why is that? This is because light chains are produced in excess to heavy chains. And there are two types of free light chains in humans, designated kappa and lambda. And increased concentration of kappa and lambda free light chains can result from reduced clearance of the kidneys or elevated polyclonal production. Thus, inflammations, infections, autoimmune disease, and hyperplasia are linked with elevated levels of serum light chains. Moreover, some study reports a correlation between serum light chains and early transplant rejection. However, patients after liver transplantation are at a risk of developing cardiovascular complications. So we decide to assess a correlation between exponent of myocardial function and free light chains in liver recipients. So our retrospective study was conducted on 31 patients hospitalized on Central Teaching Hospital with Medical University of Warsaw. And the mean age of the patients was 45 years. And we performed a test at the day of transplantation and then 2 to 3 months after on the follow-up visit. Let's move to the methods. COBAS C501 was used to determine the concentration of kappa and lambda free light chains, and NT-proBNP and troponin I was determined by dimension IXL, and the statistical analysis of the obtained results was performed in GraphPad Prism 9. And let's move to results. First graph show a significant difference in concentration of troponin I. On the day of surgery, the mean value of TNI was 0.017 nanogram per milliliter, and then after 2 to 3 months, it rised to 0.0225 nanogram per milliliter. Next graph shows also significant difference, but this time in kappa free light chains. On the day of surgery, the mean value was 33.58 milligram per liter, and then on the follow-up visit, the mean value of kappa free light chains was 45.6 milligram per liter. And the most interesting parts of the results is here. This correlation we found between concentration of kappa free light chains and troponin I. We can see a very strong correlation here, and the p-value is really low. Next correlation we find is between kappa to lambda ratio and troponin I. It's also significant. Next graph shows a significant difference in NT-proBNP concentration on the day of surgery and on the follow-up visit. On the beginning, the mean concentration was 128 picogram per milliliter, and then it was 140 picogram per milliliter. And we find the last correlation, last graph, shows association between lambda free light chains and NT-proBNP. That brings us to the conclusion. our research contributed to broadening the knowledge about biomarkers that could be useful in assessing cardiovascular risk of developing cardiovascular complications in transplant patients. Based on the results, we can say that there is a strong correlation between a concentration of kappa serum free light chains and troponin I. Thus, a damage of the heart muscle as a result of liver transplantation is associated with an increased level of in kappa free light chains production. Thank you.
Thank you very much for the presentation. The participant did not exceed the time, so I'm sharing the voice with the jury right now.
So thank you very much. The question is, does your results change the clinical practice? Or if they,
no,
do the results influence the clinical practice or change the clinical practice?
No. At
What
the
is the practical meaning of your results?
Okay. In the future, we can measure concentration of kappa free light chains, and we can prepare better our patients to complications based on the kappa free light chains.
Two questions. First, maybe easier. Did you make all laboratory analysis yourself, or it was a retrospective study?
It was made by ourselves. I also helped by in tests our patients. Okay,
and the second one. Could you present us the mechanism of the heart muscle damage related to the liver transplantation?
After operation, such as liver transplantation, the heart muscle can be I forgot the word. Can be more exposed to the damage during the transplantation, and then after, because this is a new organ and there is inflammation in our organism, and that could be influence our heart, I think.
Thank you.
Sorry, what was survival rate among your patients? So they all lived after those 2-3 months?
Yes, all 3 patients lived after 2-3 months.
All right. Okay, thank you.
Thank you very much. We did not exceed the time of the discussion. That's why we had more time for more questions. And please welcome Krzysztof Irlik, Mirela Hender works on the title of Gastrointestinal Adverse Events of Metformin Treatment. I'm sorry. Okay. In patients with type 2 diabetes mellitus, meta-analysis with meta-regression.
Good morning, ladies and gentlemen, honorable jury. My name is Krzysztof Irlik, and I represent the Department of Internal Medicine, Diabetology and Nephrology in Zabrze. And today I will have pleasure to tell you about gastrointestinal adverse events of metformin treatment in patients with type 2 diabetes mellitus from a meta-analytic perspective. So to start off, this subject is relevant because metformin remains first-line therapy in type 2 diabetes, despite new drugs coming into the market in last decades. And however, adverse events are common in patients treated with metformin, and these are usually of gastrointestinal nature. These gastrointestinal adverse events affect up to 30% of patients, and they are associated with lower adherence to metformin treatment, worse quality of life, and this may lead to treatment discontinuation. So that is why the aim of this study was to assess risk of gastrointestinal adverse events in patients with type 2 diabetes treated with metformin compared to other anti-diabetic drugs or placebo. And we also wanted to investigate whether there are other factors that influence metformin tolerance in these patients. Specifically, we tested different metformin formulations and dosage of metformin. So to do that, we pulled data from randomized controlled trials that enrolled patients with type 2 diabetes and randomized at least 20 of them to metformin treatment and rest to some other anti-diabetic drug or placebo. The primary outcomes that we measured were the risk of some specific gastrointestinal adverse events, and these were specifically abdominal pain, bloating, constipation, diarrhea, nausea, and vomiting. And the secondary outcome that we measured was the risk of therapy discontinuation due to adverse events. So initially, we searched databases such as PubMed, Embase, and clinicaltrials.gov, and we identified over 5,000 potentially eligible articles. We screened them, and we read almost 200 full-text articles, and finally, we included 71 studies into this meta-analysis. These 71 studies corresponded to 98 comparisons between metformin and some other anti-diabetic treatment or placebo, and the total number of randomized patients was over 55,000. So the first result I would like to show you are the incidences of some specific gastrointestinal adverse events. So the most common adverse event was diarrhea with a rate of approximately 13%, then bloating around 9%, nausea and abdominal pain approximately 6.5%, and the least common symptoms were constipation and vomiting. And on this forest plot, you can see risk of diarrhea in patients with type 2 diabetes treated with metformin compared to treatment with other anti-diabetic drugs. We grouped comparators into the respective class of drug. So here you can see that in every comparison of metformin treatment to some other anti-diabetic drug, treatment with metformin was associated with higher risk of diarrhea, and specifically in patients treated with thiazolidinodiones, dipeptidyl peptidase 4 inhibitors, sulfonylurea derivatives, and sodium glucose cotransporters 2 inhibitors, and also placebo, this risk of diarrhea was significantly lower than in patients treated with metformin. However, in patients treated with glucagon-like peptide 1 receptor agonists, despite the fact that the risk of diarrhea was almost twofold lower, this lower risk was not statistically significant. And on this graph, you can see the meta-regression analysis where we compared two different formulations of metformin, and every circle that you can see here represents a single trial that we included in this analysis, and the horizontal line in the middle represents the overall effect size that was calculated. And here you can see that metformin extended release was associated with lower risk of diarrhea than metformin immediate release formulation. On this graph, we have also a meta-regression analysis where we tested whether there is an association between dose size of metformin and risk of diarrhea. And here, the line in the middle is a regression line, and as you can see, it's almost horizontal. So we can also see here evidently that there is no statistically significant association between dosage of metformin and risk of diarrhea, which is, I think, a surprising finding, maybe even confusing one. And to conclude, risk of gastrointestinal adverse events is higher in patients treated with metformin than other anti-diabetic drugs overall. And we found no association between dosage of metformin and risk of gastrointestinal adverse events. And patients treated with extended release of metformin had lower risk of diarrhea than patients treated with immediate release of metformin formulation. And thank you very much for attention. And if you have any questions, I would be pleased to answer them.
Thank you very much for the presentation. The time was not exceeded, so I shall pass the microphone to the jury.
What is the novelty of your data?
Could you repeat?
What is the novelty of your data?
Yes, so the novelty of this data is the meta-regression analysis that we did included the comparison of different metformin formulations, and actually there is some conflicting results in that aspect. So there was another meta-analysis done that compared this formulation, and it concluded that there is no statistically significant difference, and some trials that were designed only to test for that single thing also had usually non-significant findings. So that is, I think, the first thing. And yeah, we also tested for some other factors of in the meta-regression analysis which are not presented here that may influence metformin intolerance.
Two questions. First, in the conclusions, you stated that generally gastrointestinal adverse effects are higher in group of metformin treatment, but you presented only the data regarding diarrhea. Did you also analyze other gastrointestinal effects, adverse effects?
Yes, we analyzed all gastrointestinal adverse effects that I mentioned in our primary outcomes. So that was abdominal pain, diarrhea, constipation, nausea, vomiting, and I think bloating.
But you didn't present these results due to a short time? Or?
Yeah, due to lack of time. I would run out of time.
Okay. And the second question, could you explain us why only in 20-30% of patients the gastrointestinal adverse effects are observed and the other ones, they are not observed?
Yeah, it's I think, a bit complicated question. I would generally say that every patient is different, and we know that generally metformin is absorbed in the intestines with OCT1 protein, that is a cation transporter, and there is very high polymorphism with regard to that protein, and some polymorphism were associated with lower risk and some other with higher risk. We also ran the meta-regression with ethnicity, including ethnicity of the participants to show that maybe some race have more adverse events than the other. However, we did not conclude anything significant there.
Thank you very much.
Thank you very much for your presentation, for the answers.
Thank you very much.
And for the questions, of course. And we shall proceed with the 9th work of today's session, the high efficacy of treatment for relapse and refractory acute lymphoblastic leukemia, by authors of Michał Razik and Patrycja Rozwadowska.
Honorable jury, esteemed audience, it is my great pleasure to be here and have an opportunity of presenting the results of our recent study of high efficacy of chemo-free treatment for relapsed and refractory acute lymphoblastic leukemia. under the auspices of the Department of Hematology and Bone Marrow Transplantation in Katowice. Just to shortly introduce you the disease itself, it is a rare disease occurring in 1.3 per 100,000 individuals annually, and it is rather considered as a childhood disease, making up to 75% of all leukemias diagnosed in the children. Although being much less frequent in the adults, it is then characterized with much worse prognosis and higher resistance to commonly administered methods of treatment. The diagnostic criterion for acute lymphoblastic leukemia is at least 20% of lymphoblasts found in bone marrow or peripheral blood. And this principal finding is followed by additional tests, which are stated here in the table. One of more recently approved drugs in treatment for acute lymphoblastic leukemia is blinatumomab, with its trade name of Blincyto. And the mechanism of action is based on what is called BiTE, a bispecific T-cell engaging antibody, which in use of patient's own immune system overcomes the resistance of cancerous cell and leads to its death. So it is an example of immunotherapy. The clinical trial, which was performed and called BLAST, resulted in high complete response in patients with positive minimal residual disease. And the other one, called TOWER, resulted in better outcomes and higher overall survival rates comparing to patients getting the standard of care chemotherapy. Blincyto is administered in 4-week cycles, and after a few days of initial stay at hospital, it can be safely taken home and administered using an ambulatory infusion pump carried by the patient. And it is both in patients with positive MRD and those with relapsed and refractory ALL, with just differences in dosing and the length of initial stay at hospital. The most common adverse effects are stated here, but according to the clinical trial of TOWER, all these were less frequent than in patients getting the standard of care chemotherapy. Moving on to our study, the aim was to assess the efficacy and safety of Blincyto in patients with relapsed and refractory ALL, and the study group involved 15 patients treated in different indications. These were late relapse, primary drug resistance, and positive MRD. In the group of patients with relapsed ALL, 4 patients achieved complete remission and then were proceeded to either allo-HSCT or the second cycle of Blincyto. One of the patients did not respond to the administered treatment. In long-term follow-up, one of the patients who achieved complete remission is still alive and is taking the second cycle of Blincyto, and those patients who were proceeded to allo-HSCT died because of post-transplantation complications. And in group of patients with drug resistance, 3 patients achieved complete remission and 2 of them did not respond to the treatment administered. All 3 patients who achieved complete remission are still alive. 2 of them were proceeded to allo-HSCT and 1 of them is getting the second cycle of Blincyto. 2 patients are deceased, with 1 of them getting the standard of care chemotherapy and then proceeded to allo-HSCT, who also presented the negative outcome of the transplantation. And the third group, the patients with positive MRD, all the patients achieved complete remission and were successfully proceeded to allo-HSCT. However, in long-term follow-up, another 3 patients died because of post-transplantation complications. When it comes to the adverse effects of Blincyto being observed in our study group, 7 patients did not complain of any complications, while 8 patients needed their infusions to be stopped because of infectious complications, neurotoxicity, and thrombosis. However, when they were properly managed, 7 patients could continue their treatment with Blincyto, and 1 patient was permanently discontinued from the treatment because of high severity of neurotoxicity, rated as grade 4. To sum up the effect of Blincyto, 3 out of 15 patients did not respond to the treatment. As many as 10 of them achieved complete remission and were successfully proceeded to allo-HSCT. Unfortunately, 9 patients died, but only 3 of them as a consequence of blinatumomab being administered. So, taking into account all the results, blinatumomab remains a prominent option in treatment for acute lymphoblastic leukemia. And with adverse effects being manageable, it can be a more effective, safer, and more comfortable in use for the patient alternative to standard of care chemotherapy. Thank you for your attention, and if you have any further questions regarding the study, feel free to ask.
Thank you very much for the presentation. I can see we have questions, so I'm passing the mic.
How can you describe your participation in the study?
Me and my friend were involved in long-term follow-up of the patients. We also collected the data from the documentation, and then were responsible for the analysis of those data taken from those trials.
Could you compare the effectiveness and safety of this drug to the other drugs used in chemotherapy in this form of leukemia?
Mm-hmm. As it is still acute lymphoblastic leukemia has rather a poor prognosis for adult patients especially, so we still need to develop some new methods of treatment, and those chemotherapy which existed until now, it was like 90% of responding patients after the first treatment, but half of them were relapsed after some time. And Blincyto is giving an option for bridging patients to allo-HSCT, which is the only method which can treat the patients completely. Of course, not the HSCT is the method of treatment itself. It doesn't treat the patient, but the intensive chemotherapy, which is served before transplanting other patients' cells to bone marrow of the patient.
Thank you very much.
Thank you.
Thank you very much for the presentation, for the questions that were asked to the participant, and we shall carry on with the 10th presentation of today's session, the number of patients with diabetes and emergency hospitalization rate in the COVID-19 era. Alexandra Vusavich, Anna Olejusz, Patrycja Pabis, Julia Pieśniak, and Wiktoria Wójcik.
Good morning, ladies and gentlemen. My name is Alexandra Vusavich, and I'm the 4th-year medicine student of the Faculty of Medical Sciences in Zabrze, Medical University of Silesia. I'm honored to be able to represent the Department of Internal Medicine, Diabetology and Nephrology in Zabrze. So today, I am going to show you what was the impact of the COVID-19 era on the number of hospitalizations of patients with diabetes and also on the emergency hospitalization rate. Now, let me move on to the plan for my presentation. So I'm going to begin with the background and the aim of our study. Later on, I'm going to present the materials and the methods, and I'm going to present the results and sum up and then I'm going to compare the data that we obtained during the research and sum up the topic by presenting the conclusions. So now let me introduce you to the background. So our study links two very important diseases, so Diabetes Mellitus and COVID-19. Diabetes is one of the most prevalent chronic diseases in the world, with the number of patients that is getting bigger and bigger each year. There are two main types of diabetes, type 1 with the autoimmune etiology and type 2 with the multifactorial etiology. There are many complications that are associated with diabetes, such as chronic kidney disease, diabetic retinopathy, and neuropathy. When it comes to COVID-19, it is the biggest medical challenge worldwide over many, many years. It is a disease that is caused by SARS-CoV-2 infection, and it can range from an asymptomatic form to the very severe course of the disease with the acute respiratory distress failure that can actually lead to death. What is very important, we still not yet know the long-term effects of the SARS-CoV-2 infection on our bodies. So now let me move on to the aim of our study. Our purpose was to compare the number of patients with diabetes that were admitted to our ward and also the rates of emergency hospitalizations during the period of 4 months, so from December to March, of 3 pandemic waves during the years 2019 to 2022, and compare it with the same months in the previous years, so from 2015 to 2018. What were the materials and the methods? So we collected the discharged patients' data of the patients that were admitted to the Department of Internal Medicine and Diabetology in Zabrze between 2015 and 2022. We created 2 databases. The first one includes 2,000 patients that were admitted between 2015 and 2020, and the second database that we are still creating, and so far it includes 658 patients. Now let me present you the results of our study. So in this chart, you can see the comparison of the number of hospitalizations before and at the beginning of the COVID-19 era. As you can clearly see, prior to the outbreak of the pandemic, the number of hospitalization was much bigger when compared to the beginning of the pandemic, so the year 2019-2020. So the number of hospitalizations in the 2019-2020 was lower when compared to the previous year. To be more accurate, it was 36% lower when compared to the year 2015-2016, 34% lower when compared to 2016-2017, 28% lower when compared to 2017-2018, and 31% lower when compared to 2018-2019. Now let's have a look at the further period of the COVID-19 era. So in this chart, you can see that the number of hospitalizations in the subsequent waves of the pandemic was much bigger. So in the 2020-2021, the number of hospitalizations was increased more than 2 times when compared to the 2019-2020, and in 2021-2022, the increase was more than 1.5 times. What about the ratio of the emergency admissions then? Please have a look at this chart. So in the years previous to the outbreak of the pandemic, the ratio was pretty stable, ranging from 21% to 33%. What did the outbreak of the pandemic change then? So at the beginning of the pandemic, the ratio was 27%, but the real change came in the subsequent waves of the pandemic, with the urgent admissions percentage of 87.5% in 2020-2021 and 90.6% of urgent admissions in 2021-2022. Now, let me conclude my presentation. So, based on the data that we analyzed and collected, the first wave of the COVID-19 pandemic had an impact on the number of patients with diabetes that were admitted to our ward when compared to the previous years. And we can show that there was a significant decline in the number of hospitalizations. However, the ratio of emergency admissions at the beginning of the pandemic and in the previous years, the years prior to the outbreak of the pandemic, were comparable. Finally, in the further period of the pandemic, not only did the number of hospitalized patients increase, but also the number of urgent hospitalizations. Thank you very much for your attention. I'll be glad to answer your questions now.
Of course. Thank you very much for the presentation. I was preparing the timer for your discussion, so for any questions, feel free to ask them.
I think that my question is obvious. Could you explain why in year 2020-2021 the incidence of hospitalizations was so high?
Well, in our study, we can show that the number of hospitalization in the further period of the pandemic was bigger. And I think it's due to the fact that at the beginning of the pandemic, there was lack of proper medical care. I mean, there were mostly remote advice from the doctors. So there was no possibility to see the doctor in person. So that can result in many complications such as diabetic decompensation. And that could lead to the bigger number of urgent admissions in the further period of the COVID-19 pandemic too.
Thank you.
Thank you.
Dr. Karavetska, maybe do you have any questions to the participant? Because we have still some time for the discussion.
Can you hear me?
Yeah. Do you have any questions for the participant?
Yes, I have a question. Did you compare only diabetic patients, or maybe you analyzed the population without diabetes mellitus, or you only concentrate on this group of patients?
In this study, we included only the patients with diabetes. We didn't compare the patients without diabetes. So probably this is the part of a larger study that will be later extended. So maybe in a further period, we are going to extend the research.
Thank you very much.
Thank you very much for both questions and answer for the presentation. And right now we will proceed with the 11th paper presented today. So, safety and effectiveness of anti-fibrotic therapy in patients with idiopathic pulmonary fibrosis by Katajina Karavetska and Dominica Pakora.
Good morning, ladies and gentlemen. My name is Dominica Pakora, and today I would like to present our work about safety and effectiveness of anti-fibrotic therapy in patients with idiopathic pulmonary fibrosis. Okay. Idiopathic pulmonary fibrosis is an incurable progressive lung disease that occurs mainly in elderly, most often in a man. There are two anti-fibrotic medicines available under the drug program, and it is nintedanib and pirfenidone, which are to slow down the disease progression. Qualification for the treatment as part of the drug program is carried out in accordance with the criteria specified in the guidelines of National Health Fund. The inclusion criteria for the treatment program include adult patients which are diagnosed with IPF based on HRCT scan after the pulmonologist has excluded known causes of the pulmonary fibrosis. If the HRCT is not sufficient to make a diagnosis, should be performed biopsy and histopathological evaluation of the lung. In addition, forced vital capacity should be above 50%. Diffusion lung capacity for carbon monoxide should be above 30%, and of course, no contraindication to the use of the drug. In the test group, we have 34 patients, including 24 men and 10 women. The average age was 70 years old. The median was 67.5. The patients were treated with nintedanib, and it was 47% of all treated, and or pirfenidone, and it was 53% of patients. Average values at the time of inclusion, which was FVC 77.73%, DLCO 50.28%, and saturation 94.76%. All patients had a disease confirmed by HRCT scan, including one patient with disease confirmed by histopathological examination. All patients were evaluated every 6 months. FVC, DLCO, and liver enzymes were assessed. The exclusion criterion from treatment program was the disease progression defined as a decrease in FVC by above 10%. Here is the table showing the number of people who achieved the particular checkpoints divided into 2 medicines. Moving on to discussing drugs separately. As you can see on the picture, the median FVC percent was before nintedanib initiation 75.5, and after 12 months it was 76.5. In the next graph, we see an overall trend of patients' FVC from subsequent checkpoints, and we can see it remains more or less constant in individual patients. Here's the comparison for DLCO. And before nintedanib initiation, it was 47.5, and after 12 months, it was 41.5. Now we turn to pirfenidone, and the median before initiation, it was 70%, and after 12 months, it was 76. The comparison of FVC before in subsequent checkpoints, we can see how patients react on this drug. The median DLCO percent before pirfenidone initiation was 51, and after 12 months it was 54. The duration of treatment ranged from 1 to 52 months. Currently, the treatment is continued by 70 out of the 34 patients. 17 patients did not continue treatment. 10 died because of the reasons listed in the table. And it was, for example, exacerbation of the disease and lung cancer, because patients with IPF are at risk of developing this type of cancer. The percentage of deaths in the study group was 29.5%. Another 7 patients did not continue treatment because, for example, disease progression, and it was 2 patients, one after pirfenidone, and it was after 24 months, and one on nintedanib after 12 months. Also, the 2 patients treated with pirfenidone have a treatment intolerance. One patient had a rash and therefore had to stop treatment after 1 month, and one had gastrointestinal side effects. Nobody discontinued treatment due to the symptoms of hepatotoxicity. A mild increase of liver enzymes occurred in 4 patients treated with nintedanib and 1 with pirfenidone. No one experienced QT prolongation. Come up to the conclusions, the treatment was effective because the disease did not progress in 91% of the study group. It was secure because no major side effects forcing for discontinuation of the treatment have been reported, and well tolerated because only 2 patients discontinued treatment due to gastrointestinal. All
on skin side effects. Thank you for your attention. Feel free to ask any questions.
Thank you very much for the presentation. Can I have any answers? Sorry. Any questions from the jury?
What were the criteria for the inclusion of the patients for two particular group of drug treatment?
It was with accordance of the criteria for National Health Fund, and it was FVC percent above 50% and DLCO above 30%, and it was the main criteria for the including in the study group.
Maybe we do not understand ourselves. I'd like to know why the particular patient was included into one group of drug treatment or into other group of drug treatment.
We didn't know exactly why, because these medicines had a similar profile about in the treatment. So there is no significant changes about one or another drug. So
actually, it was randomly because our
database is SMPT, and we don't have a data exactly. It was randomly. Yes.
Okay. Thank you.
I have a question. I want to ask about the kidney function. Was kidney function assessed in including criteria to the program?
No, it wasn't. It was no liver enzyme were, but no the kidney function.
Okay, thank you.
Thank you.
Yes, please, a round of applause. And as we began with the 12 work, just let me install the proper 12 work from Zofia Gajek. I'm terribly sorry for not preparing it properly, but with the help of my co-organizers, we managed to prepare it for you on time. So please welcome the authors of the paper, Serum procalcitonin levels and other blood test markers in patients with diagnosed, with malaria, Zofia Gajek, Magdalena Radziszewska, and Róża Przonak.
Ladies and gentlemen, we prepared our work about serum procalcitonin levels and other blood tests in patients diagnosed with malaria. And to start with, I would like to say a couple of words about this disease. Next to AIDS and tuberculosis, is still one of the biggest problems concerning public health globally. The pandemic has made it even bigger because of the lack of staff and medications in endemic areas caused by COVID-19 restrictions and limitations in transport. Nevertheless, due to broad travel opportunities, every year the number of cases of this mosquito transfer disease in countries such as Poland increases. The main symptoms are fever, headaches, and shivers. Procalcitonin is an acute phase reactant, which means its serum levels rise during inflammation, especially in cases of bacterial and fungi origin. In everyday practice, we use it to estimate the risk of sepsis. In our study, we have taken into consideration data from 16 people, 9 men and 7 women. Said individuals were admitted to the Department on Infectious Diseases and Hepatology between 2016 and 2021. The information we used concerned the PCT, PLT, CRP, liver enzymes, D-dimers, and INR serum levels. The majority of patients were infected with Plasmodium falciparum. They were returning from sub-Saharan countries and India. 12.5% returned from India with Plasmodium vivax, which is the dominant species in this region. Species of 2 Plasmodium were not determined. None of the people considered used any form of anti-malaria prophylaxis. 10 out of 16 patients had procalcitonin levels which might indicate a risk of sepsis. Despite these results, only one patient developed this condition. All of the patients in our research recovered and were discharged from the hospital in a state described as at least good. In the overview of Plasmodium species, procalcitonin levels, and parasitemia, we didn't find any correlation. The patient with the highest PCT score was in good condition during infection, and levels of parasitemia and Plasmodium species had no interconnection with the duration of hospitalization, mean 8-9 days. 3 of the patients were co-infected with dengue virus, which also didn't significantly worsen the course of malaria infection compared to other patients with only a singular diagnosis. Those are laboratory results, and procalcitonin level was elevated in 62.5% of patients. The same number had depletion in their platelet counts, and CRP was the most frequently elevated value with 87.5% of cases. The dimers were elevated in 68.8% of the patient. What is worth mentioning is that even though one of the stages of the life cycle of Plasmodium takes place in hepatocytes, level of liver enzymes were not as highly elevated as could be expected. INR, which is another liver condition indicator, was normal in all cases. Procalcitonin levels varied greatly, and no correlation between PCT levels, parasitemia, or disease severity was found. This shows that elevated PCT levels can indicate the malaria present in patients coming from tropical countries, but are not specific. Therefore, all patients with fever returning from malaria endemic regions should be considered as potentially infected with malaria, regardless of PCT, CRP, ALT, AST, and D-dimer levels. Because we must not forget that this disease is potentially fatal, it should be treated accordingly. The most efficient way to minimize this problem is using anti-malarial prophylaxis, such as mosquito nets and mosquito repellents. Thank you very much.
Thank you very much for the presentation. The participant did not exceed time, that's for sure. And let me invite you to the discussion.
So the first question, what is the prevalence of malaria in Poland? There's the first question. And the second question, do you believe that the procalcitonin level is useful for the diagnosis of malaria, as a procalcitonin may be treated as an inflammatory protein like a CRP?
Is it useful to
do you
check
think
it in the level?
if procalcitonin may be useful in the diagnosis of malaria, as a procalcitonin should be treated as a normal inflammatory protein like a C-reactive protein?
Yeah, no, and that was the purpose of the research, because it's still as commonly checked in a patient as CRP. And CRP is way cheaper. Procalcitonin is over 100 zlotys. And if we have malaria patient, we check it very frequently. Because, for example, if a patient has Plasmodium falciparum, it can rapidly develop the very dangerous state of malaria. So it's really important to have markers which can indicate this state, and procalcitonin is not one of them. And for example, in bacterial sepsis, it's super useful. So it's really important to see
so
the
is it useful or not?
It's not useful.
Okay.
And it's still being prescribed in laboratory tests for malaria patients.
But it's
without
nonsense.
any purpose.
It's nonsense,
exactly.
right? Okay. So do you know what is the prevalence of malaria in Poland?
No.
How many cases there are observed?
Sorry. Okay. So in this particular ward, there was 16 patients throughout 2016 and 2021. We had a really big problem to collect a group of patients, and I don't know the data for all Poland.
Up to 30 yearly. Up
30 yearly.
Up to 30 yearly.
Yeah,
Mm-hmm.
okay.
If the analyzed laboratory parameters are not specific for the malaria, what is the need of making this analysis?
to show that those laboratory tests, besides the things I said about procalcitonin, for example, not so much elevated liver enzymes can slow down the diagnostic process. Because we have a disease which takes place, apart from blood, in hepatocytes, and we cannot see it significantly in blood tests. So we must not think, okay, the liver enzymes are okay, so I will, go diagnostically some other route, but it cannot make us less alert when it comes to possible malaria infection.
Thank you.
Thank you very much for the presentation, for the questions and the answers. And right now, as that was one by last presentation, I would ask, I'm so sorry, I don't know what's happening. The last paper presented, that was supposed to be presented today by Mikołaj Herba, Sylwia Boczek, Justyna Kulpa, the prevalence of peripheral and cardiac autonomic neuropathy in patients with diabetes, the preliminary data. Are you here with us? Okay. Do you have your presentation on pen drive as well, or do you have 5 more minutes? I'm sorry, I will solve it in just a moment, but I have to upload once again because I don't know why it did not work when I uploaded it. I'm so sorry. So for the purpose of me preparing the last presentation, 5 minutes of break. If anyone needs to use the toilets, that's the perfect time, okay? Panie Michale, I'm sorry for speaking in English, but that's the technical part. Panie Michale, czy możemy na chwilę wyłączyć widok, żeby Państwo mogli się zalogować na swoje konta bez widoku publicznego? Thank you. I'm terribly sorry for that inconvenience to all the members. Hopefully you will not run out of here, as I have few more information after the session, as well as I would kindly ask you to join me on the stage for the commemorative photography, so please stay here, don't run away. I think we can solve it pretty soon. I'm sorry, I was not aware that it would not be working. Everything worked on my computer. Wiecie co, ja się mogę też zalogować na swojego maila. Nie, ja go mam, tylko chodzi o to, że ja się zaloguję zaraz na swojego maila uczelnianego. Jeszcze raz bardzo Was przepraszam za to, ale naprawdę nie wiem, co się stało. Pierwszy raz coś się takiego stało, ale druga osoba wysyłała mi PDF-a. Yeah, we could share the screen once again. I'm, as I said, terribly sorry for the inconvenience to both presenters and to the audience. Sometimes things don't work as we wanted them to do, but we can, I think, carry on. Thank you very much.
Thank you. Okay.
You can start.
Okay, so I cordially greet all the members of the committee and all of those who are gathered in the hall and in front of the monitors. My name is Sylwia Boczek. I'm a fourth-year student of medicine at Medical University of Silesia, and I'm pleased to show you the preliminary data from the study of the prevalence of peripheral neuropathy and cardiac autonomic neuropathy in patients with diabetes mellitus. So the first condition is peripheral neuropathy, which is caused by the damage to the nerves and typically affects feet. The symptoms are weakness of the muscles, hypersensitivity to touch, insensitivity to temperature or pain, and so on and so on. International data show that this condition affects 10 to 35% of patients with type 1 diabetes and 8 to 25% of patients with type 2 diabetes. The second condition is cardiac autonomic neuropathy, which is also caused by the damage to the nerves, but those nerves are controlling heart rate and blood pressure. So the symptoms are different. And those are, for example, orthostatic hypotension, exercise intolerance, and maybe heart palpitations. And international data show that this condition affects almost 10% of people with type 1 diabetes and 5.4% of patients with type 2 diabetes. It's also really important to say that both peripheral and cardiac autonomic neuropathy are associated with higher risk of cardiovascular events, which are most common cause of death in patients. This is why it's so important to check those patients if they have those abnormalities. So let me now present our study. The aim was to assess the prevalence of peripheral neuropathy and cardiac autonomic neuropathy in 1,000 patients with diabetes mellitus, since the actual data comes from the time of over 10 years ago. We have already examined 83 patients who have been hospitalized in diabetology ward through the last 6 months, and we collected the medical history. The first tool we use when examining patients to find peripheral neuropathy is Michigan Neuropathy Screening Instrument. And it consists of 2 parts. The first one is 15-item questionnaire, which you can see on this picture. And the second one is examination of the feet. And this feet examination is evaluating 5 different features of each limb, which are appearance of the feet, presence of ulceration, vibratory, touch sensation, and anchor reflexes. Additionally, we decided to assess also temperature and pain sensation. Another tool that we used when examining patients was DICAN, which is also called Ewing's battery. And you can see this machine on this picture with us. This machine enables diagnostics towards cardiac autonomic neuropathy and evaluates heart rate response and blood pressure response to 5 different activities. And the results of the study revealed that most commonly noted abnormality in our patient was temperature sensation disturbance, and it was found in almost 1/3 of patients. And pain sensation disturbance was observed only in patients with type 2 diabetes. Here you can see the chart showing the frequency of each finding during the feet examination. And as you can see, most commonly noted abnormality was the appearance abnormality of the feet. The remaining features were much less frequent. Here you can see the results of the Michigan Neuropathy Screening Instrument. And as you can see in both parts of this study, the questionnaire and physical examination, abnormal results were found only in patients with type 2 diabetes, and more abnormal results were observed in the questionnaire part of this study. And to say that patient has peripheral neuropathy, he must have abnormal result in both parts of this study, I mean in the questionnaire and during the feed examination. And those requirements were met by 6.5% of patients with type 2 diabetes, while not even one person with type 1 diabetes was found to have peripheral neuropathy. And here you can see the results of cardiac autonomic neuropathy study. Definite or severe involvement should be obtained to recognize this condition. We have only 4% of patients with type 1 diabetes who have severe involvement and have recognized cardiac autonomic neuropathy. And we also have 18% of patients with type 2 diabetes who have recognized cardiac autonomic neuropathy. And to conclude, as you can see, the prevalence of peripheral neuropathy and cardiac autonomic neuropathy doesn't seem to be comparable to the international data. Because in patients with type 1 diabetes, cardiac autonomic neuropathy is lower, and in patients with type 2 diabetes is higher than international data are showing. And peripheral neuropathy is lower in both groups of patients. These results might highlight the importance for screening for cardiac autonomic neuropathy to being crucial for the management of diabetes and to treat those complications, especially cardiovascular. But as it was mentioned before, this study is preliminary and more patients are needed to be studied. And that's all. Thank you for your attention.
Thank you very much for the presentation, and once again, I'm so sorry for the inconvenience before. So we shall proceed with the last discussion of this session.
Why do you think, why in the type 2 diabetes patients there was higher incidence of neuropathy?
Generally, patients with type 2 diabetes have longer silent diabetes. They aren't found to have diabetes previously, so they are living with these high levels of sugar in the bloodstream. And I think that is the cause of bigger amount of patients with peripheral neuropathy and cardiac autonomic neuropathy, because they are living with this high level of blood, of glucose levels, and they are destroying the microvascular vessels and arteries.
Thank you.
Thank you.
Was it a prospective or retrospective study?
Prospective.
Prospective, okay. Did you find the differences between type 1 and type 2 diabetes, of course, despite of the low number of patients, statistically significant, or you didn't compare it yet?
Pardon? Could you?
Did you find the next slide? Yeah, and yeah, more. I mean, you show that there was a difference in 12 to 2% between type 1 and type 2 diabetes. Mm-hmm. Did you find them statistically significant, or you didn't compare it yet?
We didn't compare it yet.
All right, thank you.
Do you know which of the senses disappears as the first one?
Could you ask me again?
Which of the senses disappears as the first one?
I think that those are temperature sensation disturbances, due to the fact that they occurred in most of the patients. So
I'm asking generally, just a little bit beside your study.
Mm-hmm. No, we didn't check it.
Vibration. Okay.
Thank you.
Thank you very much for the last presentation of today. If I can have Dr. Karavetska on the screen for the ending, that would be incredible. Okay. Hello, once again. I will go with the second one. First of all, I'm sorry for all the inconvenience that happened today. Hopefully it did not influence your presentation as much as it could. That was my mistake. I'm terribly sorry for that. But dear participants, thank you all for coming, for joining us, for sharing months of your work, the incredible outcomes of your researches with us, for sharing that knowledge and giving your particle to the science that we have, that we are experiencing. Dear jury, thank you for coming today, for joining us, for honoring us as the participants, as the organizers with your presence. Quick reminder to you all, after the session I will be gathering and collecting your assessment cards, so please do not run out with them. And Dr. Karavetska, I would kindly ask you to send your assessment card to me by email after the session ending. And right now, I would ask the president of our jury, Professor Michał Cholecki, to sum up the internal medicine session for us.
Dear colleagues, it was a very interesting session. Thank you very much, because you showed us some very interesting presentation. You were involved in a very, your involvement was very, very high. Just let us 10 minutes to summarize our decision, and you will know it within the next 10 minutes.
No, it will be shared on the closing
ceremony. Okay, so you have at least 5 hours free. Thank you very much.
Thank you very much for sharing the thoughts and highlighting the closing ceremony. As you heard, the results will be announced on the closing ceremony, which will be held on 4:45 p.m. Here in this hall. Thank you very much. I'm forgetting the words in English. It's my luck that I'm not the presenter right now. And for the closing, I have 2 more informations for you. First of all, I would cordially invite you all to take part in our Instagram giveaway, which we prepared for the participants of the SIMC 2022. All the details are listed in the Instagram post about it. And we have quite awesome presents for our winners, so you have to check it. And lastly, I would like to invite you all, both the participants and the jury member, to join me on the stage for the commemorative photo. Please, come join me.